Good evening, everyone. I am Dr. Sengulvan, Executive Director, Kauvery Hospital. உங்க எல்லாருக்கும் தெரியும், கொரோனா ஃபர்ஸ்ட் வந்த உடனே காவேரி ஹாஸ்பிட்டல் தான் ஃபர்ஸ்ட் the government we said we'll take care of corona patient அப்படிங்கிற ஒரு இதோட ஆரம்பிச்சோம். ஸோ கொரோனாக்காக தனியாக ஒரு வார்டு தென்னூரில் தனி பிளாக் இது பண்ணி 150 பெட்டட் வார்டு கிரியேட் பண்ணோம். We handled so many category of patients from newborn இருந்து ஆரம்பிச்சு 90 வயசு ஆளுங்க முடிய we managed. அதுலேயும் ஸ்பெஷலாக pediatrics, the only private sector handle so much of pediatric COVID patient is only from the Kauvery Hospital. அந்தளவு pediatric நல்லா பண்ண முடிஞ்சதுக்கு எங்களோட டீம் தான் மெயின் காரணம். I like to introduce my team members to the forum. Dr. Suresh Chalaya, Senior of Pediatrician and Head of the Department, Head of the Pediatrics Department, Kauvery Hospital. Dr. Sendil, the Neonatologist, Head of Newborn Neonatology Department in Kauvery Hospital. And Dr. Meghanathan is a pillar in managing the COVID ward. Dr. Vignesh, another pillar in managing the COVID ward, both are consultant pediatricians. This is a team that had a wonderful experience and treated so many COVID patients in this region. And today we are going to share our experience to you. What are the types of cases we have seen and what are the complications we have come across. And if you have any queries, if the time permits, definitely we'll answer. You can put it in the chat box. We'll try to answer all your queries if time permits. Dr. Suresh, you've been doing the practice for the past more than 3 decades in Trichy. So how do you feel about this pandemic that affected Trichy, especially of pediatric age group?
Thank you. Good evening, everybody. I would like to start with a small story as usual, and that's like next slide. That's slide. Yeah, this is a story about Lord Buddha. ஒரு தேடி போய் புத்தர்கிட்ட என் பையன் இறந்து போயிட்டாரு, அவர் எப்படியாவது அவரை உயிர்ப்பிச்சு கொடுங்க, மேக் ஹிம் அலைவ் அப்படின்னா. புத்தர் சொன்னாரு, சரிம்மா நான் பண்றேன், ஆனா எந்த இறப்புமே இல்லாத ஒரு வீட்டுல போய் ஒரு பிடி உப்பு வாங்கிட்டு வாங்க, நான் பண்ணித்தரேன் அப்படின்னு. இந்த அம்மாவும் போய் ஊர் ஃபுல்லா தேடி பார்த்தாங்க, அந்த மாதிரி எந்த வீடுமே இல்லை. எல்லா வீடுகளிலுமே இறப்பு நடந்துட்டு தான் இருந்தது. அவங்க திருப்பி வந்து இறப்புன்றது எல்லா வீடுகள்லையும் நடக்கும் அப்படின்றத யோசித்தாங்க. கொரோனாவும் கிட்டத்தட்ட அந்த மாதிரி தான். ஆரம்பிச்சப்போ நம்ம குழந்தைகளுக்கு ஒன்று வராதுன்னு நினச்சோம், நமக்கு வராது, மற்றவங்களுக்கு வரும்னு நினச்சோம். பட் கிட்டத்தட்ட எல்லா குடும்பங்கள்லையுமே நமக்கு நெருங்கியவர்களோ தூரத்து சொந்தமோ யாரோ ஒருத்தருக்கு இந்த கொரோனா வந்து அதனால் உள்ள பாதிப்புகள் மைல்டாவோ சிவியராவோ வந்திருக்குது. நிறைய மருத்துவர்கள், எங்கள் மருத்துவ நண்பர்களுக்கும் வந்திருக்குது. ஸோ இந்த கொரோனா கூட நம்ம வாழ கற்றுக்கிட்டோம். இப்போ கொரோனாவை பற்றி most people think it is a mild illness in children. That is what we were told when we started this epidemic about 9-10 months ago. We were told this does not affect children. Children are safe. There is no issues. They will only be asymptomatic. And that was what we were told. And we believed that to begin with. But is it true? It is not. In our experience, we've had in the acute stage of illness, we had a few problems. And in the later convalescent stage, which is what we are facing right now, we've had many problems, many children who are becoming very sick. So it is not a mild illness in children, it can be a severe illness in children. Because of the number of adults involved, it has become this childhood illness is not being portrayed as an important one. So in this half an hour to 1 hour, we will go through the cases that we saw, the causes for these cases, the course of the illness, confounding issues that we all faced, and the difficulties in care that we had to give for our children. So our panel will discuss all these things in detail. So Please ask us any questions if you have any. Thank you.
So nice, Raj. Very nice. So earlier they've been saying pediatric patients will not get affected because of the COVID, and then they said pediatric patients may get affected. But as of you, I mean, as per your experience, you are seeing a lot of COVID positive children, both asymptomatic as well as symptomatic, as well as with the complication. That is what.
100 children with COVID, a few of them were very sick. Most of them were not were asymptomatic to begin with. Now we are seeing another spectrum of the same illness, which we will discuss.
So one point is children also getting affected, sometimes with complication. That's fine. Meghnadhan, டாக்டர் சுரேஷ் சொல்றாங்க இந்த மாதிரி நிறைய கோவிட் கேஸ் பார்க்குறோம், சிம்டமேட்டிக்கும் பார்க்கணும் அப்படிங்கிற மாதிரி சொல்லுங்க. நீங்க மெயினா யூ ஆர் been a frontline warrior, especially the COVID war is managed by you as well as Dr. Vignesh, you are the main pillar. What is your experiences? What are the type of cases that you have seen? Will you be able to say some of your experiences here?
Good evening to all. As the COVID pandemic started, we also started a separate COVID ward in Kauvery unit. Initially, we used to treat the cases experience are very wonderful. Initially, we used to treat asymptomatic cases. Then, as the case load is high, then we used to treat mild symptomatic cases. When the case load is become very high, there are few patients come very sick with need challenging management. I want to share a few of the cases, especially the children which had a very tough to manage, and the various presentation. I want to share in the active infection of the COVID. So this is the first case I want to discuss with you, sir. This is a 8-month-old female baby presented to triage with vomiting, blood-stained stools, and fever for 2 days. On triage, the child was in shock, cold periphery, CRT prolonged, and weak periphery pulses. And per abdomen was distended. There was a diffuse tenderness and rigidity was present. So the child was initially stabilized with IV fluids, IV antibiotics, and other supportive measures. So acute intussusception was considered in this baby. We took X-ray abdomen. It was dilated small bowel loop with multiple air fluid levels, and ultrasound abdomen was suggested by intussusception. Again, CT confirmed that there was a ileocolic obstruction. With this background, we move on to next level of investigation while managing the shock and other parameters of the baby. The hemoglobin was 10.5 and the rise total counts. The RFT and coagulation profile was within normal limit. We move on to next set of investigation. The RT-PCR COVID was positive. There was a high D-dimer and Procalt, and the CRP was high. We did a screening CT also for this baby. There started to be a severity score of 5 for COVID. In this infective case, we will move on to further management for this baby. We immediately shifted the baby to isolation ward, and we tried ultrasound guided heteroreduction, which could not be possible. And at the emergency procedure, we shifted the baby to emergency 40. We operated on this COVID-19 patient with all precaution measures. There in intraoperative, we tried for manual resection, which could not be possible. Then we exercise and did end-to-end ileoileal anastomosis, and the child needed very post-operative care was very tougher for us. The child needed ventilator support and ambulatory support in post-operatively. The shock was recovered in the day 3, and the child was extubated on the day 2. The child was shifted to face mark on day 4, and we have started oral feed on day 5. So by day 6, the child shows reducing in the inflammatory marker. The child become afebrile. By day 10, we discharge the baby. But thing in this baby is the challenging effect is this is the 8-month baby presented shock with the COVID positive at the earlier pandemic phase. We found very tough to manage the patient in the isolation ICU with the PPE kits, with our dedicated staff nurse. And the initial 2 days were very tougher for us because the child is on ventilator support. The child was shocked. We tightened the inotropes. We cleaned up the patient. In the bedside, we put duty for the doctor by bedside. Round the clock, we cover the patient, and we treated the baby successfully, and the baby was discharged on day 10. And during follow-up, we had doubt. This is the first case we had as a COVID positive intercession. Whether this COVID-19 is caused intercession, there is any other thing. We did COVID IgG antibody, it was significantly high. So the COVID-19 could be a cause for the intercession.
Oh, that's wonderful. My sincere appreciation to you and the surgical team, but back to you, Meghnadhan. And you said in the initial phase that everyone was feared about COVID and no one was not willing to work in COVID ward. That time you've been courageously handled the active COVID infection and you did a surgery and managed 48 hours with ventilator. It's a wonderful work or excellent work done by you and your team, Meganathan.
Another case also came, sir. Then after 1 month, they another one same presentation of interest in that patient also we post-op need ventilatory support. That case also managed.
So two surgeries
yes,
for intussusception, you
COVID.
did it in the active COVID patient.
Active COVID.
That's great. That's great. Is that only the manifestation or any other thing that you have seen?
Another one different manifestation we had recently, sir. This is a 10-year-old female child treated elsewhere for fever with thrombocytopenia and discharged in the recovery phase with platelet count of 1.25. And the very next day after discharge, the child was present to our side with his sister and uncle morning. In trials, the child was hemodynamic stable, there was altered sensorium, there is no meningeal signs, there is no focal neurological deficit, and other neurological systems were within normal limit. We manage the child with IV fluids and antibiotics and anti-epileptics. We move on to next level investigation. The RT-PCR code for positive and CRP was negative, and the dengue NS1 in IgM were negative. The counts were normal. The slightly elevated high D-dimer and ferritin was within normal limit. We did the MRI. We could find one different type of lesion. It's new for us, everyone. This is a cytotoxic lesions of the corpus callosum. So this is typical boomerang sign. Is a cytotoxic lesion of the corpus callosum. This cytotoxic lesion of the corpus callosum, etiology was very few. This is caused by because of vasculitis, some metabolic causes, some viral illness, and COVID-19 also one of the cause for this cytotoxic lesion of the corpus callosum. So this patient present with altered sensorium, we did MRI. This suggested was a cytotoxic lesions of the corpus callosum. We managed the child with anti-epileptics and other supportive care, and on day 7 of the hospital stay, we discharged the child with normal neurological status. Now the child is on follow-up with antibiotics. The child is doing good with normal sensorium. Sir. This is another manifestation. So usually the thought process was the COVID is only respiratory, but we see most of the sick patients were involved in other system. The first case was involved in the GA system with artificial infection. The second case is presented with like meningoencephalitis feature with positive findings in MRI. Sir. But both children we managed well and both are doing good. Sir.
Okay. So the active COVID infection can manifest in the form of altered sensorium or a CNS manifestation. It can manifest. That's good. And another MRI, it's a classical boomerang sign. Yes. That's great, and I think we are able to see it in MRI very well. And instead of boomerang sign, one of the evidence of the COVID infection in MRI. That's good. Okay, thank you, Meganathan. Dr. Senthil, Meganathan on the COVID ward on the pediatric experience. As a neonatologist of this region, what is your experience of COVID in the newborn?
As Suresh told, everyone thought that as age decreases, the severity of the COVID infection is less, but actually it is not as we do see an newborn with COVID complications can able to save a child, and we can able to predict the severities. So these are the things we done last couple of months. We get aware of that COVID, and we can go into it. Now we are very confident in handling and treating an COVID.
Okay, so in newborn also now initially there was thought that it was not affected newborn. Now you started seeing the cases being affected with COVID, and you started handling it, and you are very comfortable to handle things. Very good. What are the manifestations? Do you think what are the types? How they manifest? How they behave?
First, when you are going to suspect newborn COVID, it is very tricky thing. When to suspect is first whether we can categorize it like that. One is with the symptomatic. Okay, if you have any symptoms, then there's a chances for suspecting an COVID. And another one is an asymptomatic newborn. How we are going to discuss? How we are going to suspect in that babies. So symptoms, classical symptoms, what we come across And yes. Yeah, what the classical symptoms we come across is persistent fever. So whenever there are any child with a fever, with an respiratory symptoms, first we think of whether we are dealing with an COVID. And another thing is, we are unusual presentations we had come across is some seizure and some J symptoms. Actually, these two symptoms will mask the COVID. So we must be very aware that whenever there is a fever with seizure or fever with any J symptom or fever with any respiratory distress or cough, must be very aware that go forward and do a COVID test. First point is one. Second is in an asymptomatic. Okay, fine. Many newborns won't present with any symptoms. So for that, you must get an history of one contact with an adult within 14 days. Any contact with a fever or a cough, or in many conditions, the mother itself became COVID positive. We come across so many babies born to on COVID positive mothers, and we found that around 2 to 3% of the babies born to COVID positive mothers having a COVID positive infection, but they are asymptomatic. So the perinatal, although we can say that 2 to 3% is the chances for having perinatal transmission, even though that these babies doesn't have any symptom, they have only complications related to one newborn, and their inflammatory markers at that point of time is not much high. Whereas symptomatic babies, which is presenting 2 weeks or 3 weeks later, and they have high increases in inflammatory markers. And we find that presence of seizures and GE symptoms mask us to think of COVID. So we interpret COVID late. So my sincere thing is, with our experience, we concluded that whenever a baby presented with fever or with any other symptoms with fever, seizures or GA symptoms, you are not responding with an initial, not 2 days, go forward to do an inflammatory markers. Don't go.
Okay. So in newborn, it may manifest asymptomatic,
Yeah.
symptomatic. Usually, a high index of suspicion is necessary to diagnose COVID in the newborn, and especially if the child comes after a week or two, then they are more prone with all rising inflammatory markers and going for the sick conditions. And they manifest in the form of either respiratory distress or in the form of seizures. CA symptoms also.
But
Is there any cardiac involvement in the newborn?
Yeah, that's going to be an prognostication. If you're having a myocardial dysfunction, but with pericardial effusion is there, we find it's an indicator of an poor prognosis and
Okay. If there is cardiac involvement, usually many times it will be associated with pericardial effusion also. That indicates little poor prognosis for the newborn. That's wonderful. And then, what do you feel about the feeding of the babies? How do you feel the feeding of the babies?
So, when coming to an feeding, so whether the mother is positive, baby is negative, or baby is positive, mother is negative, or both are positive, treatment, the choice of thing is only an breastfeed. So no more formula feed. It gives much advantages. It's a feed for a baby. It gives a much advantages. The immune system of the baby is also get improved with breastfeeding. But we must take some precautions while giving and breastfeeding. Mother should wear an N95 mask and should have a cough hygiene and should have use an hand sanitizer. Should we place a baby up to 3 feet away after the feed? These routine precautions is enough for them to have an.
According to your experience, breastfeeding should be continued, and some special precautions should be taken up by the mother, but like wearing the mask and taking the baby away or during non-feeding time. Treatment. What are the treatment that you like to do in the newborn?
Usually, sir, we have only a supportive management initially. Fevers, antipyretics. We have some basic inflammatory markers. We look for search for inflammatory markers, and we maintain the oxygenation, perfusion, temperature. These supportive cares will be an. And we find that okay, the inflammatory markers are high, increasing trend. We find that steroids, especially dexamethasone, holds good and be a lifesaver for that With our experience in our unit, so dexamethasone is a life changer. So it's giving and saves more babies. Not critical illness.
Very good. According to you, see, supporting measures and steroids plays a major role in the treatment of the newborn COVID. Is there any role for IVIG?
Some centers has been used, but there is also evidence is emerging that we can also use an IVIG.
Here, one doctor is asked, sir, kindly opine about plasma therapy in children. So, I'd like to get opinion from Dr. Senthil in newborn and from Dr. Suresh in children.
As far as for plasma therapy for a newborn, even we the center has been given any plasma therapy for a newborn or any no molecular weight parent. As of now, steroids and IVIG is an
Okay.
treatment.
So, in newborn, there is no role for plasma therapy. As of now, there is
As
no
of now,
evidence.
no evidence is favored for it.
Suresh, in pediatric, what do you feel like plasma therapy?
A good question. Actually, the problems that we see in children are more often due to antibody mediated diseases than the actual infection itself. Maybe adolescents and young adults, they are seeing patients, but most of them are not very sick. So there is not enough evidence to say plasma therapy works in small children, and not many centers have used it, mainly because they've not had so many acute cases of sick COVID children as against newborn when they are very sick, and the other end of spectrum, convalescent disease. So plasma therapy is not been used in children so far.
So, probably with your team that you will be able to try and prove that it's effective or not effective.
I'm hoping that will go up, not come. We won't come to that.
Good, Senthil. Next, Vignesh, Dr. Senthil was saying about the newborn and Meghanathan was saying about his experiences in the COVID ward. You are also one of the main pillar in COVID ward in so many cases. What is your experiences and do you see any post-COVID complication like cases or what is your experience about?
Yes, sir. So good evening to everyone. I first of all thank Kauvery management for giving me this wonderful experience for the past 9 months. So we have to handle the COVID duties. So we are seeing so many varieties of cases. So the two post-COVID complications cases, we have seen so many cases. So I want to share few cases. So in past 20 minutes, Dr. Meghan and Dr. Senthil sir have seen active cases involvement. So I am going to share the post-COVID complication cases. So this is the first case, 7-year-old female presented with day 8 fever, loose stools and abdomen pain for 2 days. Her father COVID positive 1 month back. So this child treated elsewhere and came here for further care. So in triage, the child was looked dull, presented with hypotensive shock. So his systemic examination was mild abdominal distension with diffuse tenderness was there. So any child came with fever with hypotensive shock. Once we will secure the line and take out the sample, the first and earliest we will take bedside screening echo. So in this bedside screening echo, we will assess two status, one the fluid status and this cardiac contractility. So depends upon these two parameters, we will titrate the fluid. We should not overload, we should not underestimate, we should titrate the fluid first and foremost. So for this child, we have it moderate to severe LV dysfunction. So next, the lab investigation. So for this child, has a mild thrombocytopenia with elevated inflammatory markers and high D-dimer level with have a mild coagulopathy also. The COVID IgG turns to be positive in this child. Next. So we have done this echo for this child. So in this, we have moderate to severe LV dysfunction. So we usually will assess the Z score. In this child, Z score is almost 9. So evidence of more than 4, we should cardiac coronary artery involvement. For this child, Z score is 9. So definitely coronary artery involvement was there. So we managed this child successfully with our treatment. So what made us to diagnose MAC with this child? So for this child, fever for more than 3 days, acute GI problems like loose stools and abdomen pain, came with hypotensive shock and evidence of coagulopathy with TT and D-dimer and elevated inflammatory markers of CRP and ESR, and COVID IgG was positive, antibody levels more than 100 with echo findings of moderate to severe LV dysfunction with coronary artery involvement. So with these points, we diagnosed as MAC category 3. So this is a case of category 3 multi-system inflammatory syndrome in children. This mainly involved the cardiac, so this is called as MASC3 with cardiac dysfunction. So this child developed on day 3 had tachypnea, so we started on high flow nasal oxygen. So then again we reassessed the echo, so it has a moderate LV dysfunction, IVC was adequate, so we restrict the fluid and started Lasix infusion and started on digoxin. So coming to treatment mortality, then as per lab reports, usually in our unit protocol, we'll usually have a set of parameters with all inflammatory markers. We'll do day 1, day 4 and 1 day before discharge. So as per the effective treatment, all the inflammatory parameters came down and the platelet counts have started rising. So as per next we'll come to treatment. So any category 3, first and foremost, we should start with fluid resuscitation. If not response to fluid, it's going for inotropes and respiratory support. Any child with cardiac involvement, we should give IV pulse dose methylprednisolone followed by IV Ig, sir. If the child is having coronary artery involvement, this child is having coronary involvement, so we started on aspirin 3 to 5 mg per kg per day. So this child is having elevated D-dimer level, so we started on low molecular heparin, mainly we started enoxaparin, sir. So with this continuous monitoring this child with active fluid management and proper IVIG and proper pulse dose methylprednisolone, so we managed successfully. This child was almost 10 days in ICU. We properly with our team, with our dedicated staff nurse, with our team cardiologist and our dedicated pediatricians, we have managed successfully. This child came with review. The child is now all the parameters are set to normal level. The child parents are happy, sir.
Yes, I got few queries for that. I like to appreciate. Done echo screening by bedside by yourself. I think nowadays youngsters become a more techie person and they are able to utilize the technology in the casualty itself. I think that helped you in managing your fluid status for the child. Suresh, you want to say something?
It is not just in bedside echo at admission. Every day when I go for rounds, or when anybody comes for rounds, I get this is the LV function, this is LV dysfunction is there, this much of fluid we are giving. So the constant monitoring with our echo and ultrasound has helped us manage these children. From dengue, we've learned all that, and now we're using it for this in a much better way. And this is all very labor intensive. Dr. Vignesh has finished it in one slide, but this takes a lot of effort to get this done. It's not an easy job at all, and the team is doing an excellent job now.
Doing on routine screening, echo screening on a day-to-day, every day, monitoring the patients helps.
The title the fluid should not overload, sir. We are doing daily echo screening, sir.
Okay. And another thing that you said, coronary involvement, then we have to go for an aspirin.
Yes, sir. That too in aspirin, I want to specify, sir. Before starting aspirin, we should check for platelet count. If platelet count is more than 3 lakhs, we can give aspirin. If platelet count is less than 1.5 lakhs, it's thrombocytopenia, we should withhold aspirin, sir. This is a point highlighted.
Okay. More than 3 lakhs, you can start an aspirin. More less than 1.5 lakhs, it should. Anything if it is between that anything? So
Yes, sir.
Above 1.5 lakhs is probably safe to start if the coronary involvement is severe.
Yeah.
But above 3 it's quite safe. Below 1.5 we should be wary of starting aspirin on a child. See, we are already giving enoxaparin, so bleeding may occur. So it's a very each case by case we'll have to decide.
Yeah, that's fine.
At that point.
So, okay. Aspirin then in generally if it is less than 1.5, you should not start.
Yes, sir. That's
a
right.
point.
Yes, sir. That's
won't
right.
start.
Is there any other experience that you want to share?
Yes, sir. I can one more case to present all. There's a 14-year-old came with day 5 fever, blue stools, red color urine, conjunctival congestion with generalized body rashes. So this child came to triage. Child is in hypotensive shock, dull look. So BP was almost 60 by 60 Cori. So systemic examination is abdominal soft and epigastric tenderness was there. Again, so the first and foremost tool is bedside echo. Since child in hypotensive shock, we will do bedside echo. For this child is having mild LV dysfunction. So then thin rim of pericardial effusion, sir. For this child, there is no coronary artery involvement. For this child, IVC is adequate. So we should not volume overload the child. So coming to next. So this child, day 1 labs has elevated inflammatory markers with COVID IgG was turned to be positive. There's one more point I want to highlight. For this child, elevated urea and creatinine and urine proteins was numerous RBCs. So this child having both cardiac involvement as well as renal also is got involved. So next slide. So what made us to diagnose MAC in this child? So this child had a fever of 5 days, generalized body rashes, blue stools, bilateral conjunctival congestion, presented with hypotensive shock and evidence of coagulopathy and elevated inflammatory markers. COVID IgG was positive and LV dysfunction with normal coronary artery involvement. Next. So this is turned to be category 3 MAC, multi-system inflammatory syndrome in children with cardiac dysfunction and kidney injury also. So on regular days-based injury, this child have all the inflammatory markers are improving trend. So except this child, while on discharge, the D-dimer only value was increasing trend, sir. So we coming on to the treatment aspect. So as I told earlier, first and foremost, fluid resuscitation and proper inotropic support and respiratory support. This child is having also a cardiac involvement. So we start on pulse dose methylprednisolone followed by IVIG. I want to specify there is no coronary artery involvement in this child, so we didn't start aspirin in this child. This child is having elevated D-dimer level, so we started on low molecular weight heparin. So one day before discharge, we done a D-dimer for this child. It's having rising trend. So this child we discharged with subcutaneous low molecular weight heparin. So this child came review. We checked again D-dimer level. The D-dimer level was normal now. So all the parameters now the child almost came 1 week back. The child was came review, sir. All the parameters are normal. The parents are really happy. They appreciate our team very nicely.
Good. So last case you were about the cardiac involvement with coronary artery trauma. And this case primarily affected the kidney.
Yes, sir.
Cardiac
as well as
without affecting the coronary. Yeah, Suresh, இப்ப Vignesh has been telling you about the MASC complication அதுன்னு சொல்லிருக்காரு. Like to know what is, yes, he's saying category 3 அப்படிங்கிறாரு. I would like to know what is MASC, how he categorizes the patient, how it is influencing our management. I'd like to know from you, Suresh.
MAC has become like MISA for us. Those days. People who lived in the emergency time would remember MISA. MISC is a newly diagnosed or newly recognized multi-organ disease, multi-system inflammatory syndrome in children. So as the name implies, there is many system, there is inflammation. So this is presumed to be a delayed immune-mediated complications of the SARS-CoV-2 infection, but it can be life-threatening and requires a lot of complex multidisciplinary care. Early recognition is very important to prevent complications and serious sequelae. Like I said in the beginning, a lot of our children will have antibody positive, but they all do not have MASC. So we have to have diagnostic criteria which has to be strictly followed, as we have learned in our experience here. Age should be less than 19 years and a fever for more than 3 days with evidence of inflammation, CRP positive, ESR high, and a SARS-CoV-2 exposure, either an RT-PCR that is positive or an antibody test or a contact with COVID-19. We should exclude all other microbial causes like a UTI or a sepsis or a typhoid or scrub typhus, which can have all these things. And at least 2 organs should be involved, mucocutaneous signs like in Kawasaki disease, shock or hypotension, cardiac involvement without shock like a pericardial effusion, coagulopathy, either an abnormal PT-PTT or a high D-dimer, and a gastrointestinal symptoms like abdominal pain, vomiting and diarrhea. Now this is a diagnostic criteria for MASC. And what will we do when we see a child with MASC? The first thing is red flag signs, like in any disease, altered consciousness, unresponsiveness, respiratory distress or signs of shock or heart failure. These are children who are sick. They should be taken to the ICU. Resuscitation should be started immediately and then investigated. If there are no red flag signs, the child is conscious, the child is hemodynamically stable, and there is no distress, then we can proceed to diagnostic evaluation and treatment, which I'll explain in this slide. Now, if there is fever for more than 72 hours and at least 2 features, rash, GI symptoms, edema of hand, oral mucosal changes, conjunctivitis, and lymphadenopathy. If you look at this group of symptoms and signs, this looks very much like Kawasaki disease, which is an inflammatory disease of the blood vessels. This is exactly what happens in MISC also. There is a lot of vasculitis due to an autoimmune disorder or an immune complex disorder or an immune mediated disorder. So when we have this usually presents in older children. Kawasaki will be in younger children, like really like 1 to 2 years, less than 1 year. But this comes in more in older children. So we have to consider MISC and look for shock. So next slide. There are two tiers of investigations we can do, tier 1, tier 2. If there is shock, we should do both. If there is no shock, we can do tier 1 investigation, which will be inflammatory markers, electrolytes, creatinine, sugar, LFT with serum proteins, COVID-19 PCR or COVID antibody, depending on the situation. And the tier 2, if these are positive, tier 2 will be LDH, ferritin, triglycerides, PTA, PTT, INR, echo and an ultrasound abdomen. This will complete the investigations in any child with suspected MISC. This is a must. Next slide. Now to categorize this illness, because this illness is a new illness, they have put 3 categories, and a lot of papers have come from Europe and the US. China, surprisingly, not many have come out with this particular paper, problem. But US and Europe they put out a lot of studies on this. And category 1 is if there is no hemodynamic instability. If the child is improving clinically and inflammatory parameters are improving on supportive care, and that is category 1. So we will start only oral prednisolone, IV methylprednisolone for 7 days. We will taper it over 2 weeks. We will monitor echo and inflammatory parameters to see if they slip into category 2 or 3 every day. Parameters will be repeated every 2 days or 4 days depending on the unit protocol, but echo has to be done preferably every day to make sure cardiac involvement does not come, can be very incident. Next slide. Category 2 will be like a Kawasaki disease, conjunctivitis, lymph node enlargement, and rash, oral mucosal changes, and there will be no improvement on supportive care. Cardiac involvement may or may not be present, and this has to be treated with IVIG, aspirin, low molecular weight heparin, like Dr. Vignesh has explained. If you see the 2 cases, the acute cases that Dr. Meghnathan was describing, inflammatory markers were negative. CRP was negative or low. In the interception case, he mentioned 65. The other clocks, a child, it was negative. Whereas whatever Dr. Vignesh was mentioning, it was all 300, 200. So these high inflammatory markers should raise our suspicion to this particular illness. Next slide. Category 3, next slide, will be worsening of inflammatory markers. When we do on day 1, day 3, there will be worsening. Child is going to shock. Cardiac involvement will be present, and this child is very sick. This child needs IG, IV methylprednisolone, and rigorous monitoring inside a good ICU with the help of cardiologists and intensivists and anesthetists if possible. We need a multidisciplinary approach to treat this category 3 children, and that our team effort, the entire team of our youngsters and help people who help us is what has got these children out. All none of our children we have had a bad experience with, mainly because of our teamwork.
So you feel to suspect on MISC, that is, it is a vasculitis involving the multiple systems, and usually it presents with the fever, with the evidence of COVID positivity, along with that certain clinical signs and symptoms. In this, we can suspect on MISC. In that, you want to categorize. That's what the management says. So category 1 is a stable patient with simple COVID positive with the signs and symptoms. Category 2 is associated with, like, it behaves like Kawasaki, the rising of inflammatory markers still more. Category 3 is present with shock or cardiac involvement and other system involvement.
I should add that we should rule out other bacterial illnesses or viral illnesses during this period. So index of suspicion should be high, but we should not jump to conclusion saying this is MISC and ignore the other common illnesses that are still there in our community.
You want to stress the point that other infections should be ruled out before making an MASC.
MASC diagnosis. We should not delay the diagnosis of MASC, but we should also, in the meantime, rule out other bacterial infections clinically and investigation wise, which is equally important.
Now you've been categorized. How you are going to manage these children? So how do you manage category 1? How do you manage
next slide. Dr. Vignesh will explain a few more of our cases now. He wants to have a few cases and then we will go back into
then we'll go. Okay. Meghna, then, if, what do you feel like? Vignesh was saying that he's seen the case with an FRI case, he's seen with case of cardiac involvement, and Suresh says it can affect any system. You have seen any cases affecting other than this cardiac or nephritis? Other system has been involved. What's your experience on that?
As the name implies, it's a multi-system immunity syndrome. We have seen almost all systems. As Dr. Vignesh discussed a few of the cardiac and nephro, I want to further discuss about the other system involvement. There have been cases in all systems, almost all systems involved. I want to share this case. This is a very interesting case. This is an 8-year-old boy presented to us with a fever of 4 days. There were no localizing history. There is no other positive history. On examination, the child was hemoglobin stable, was febrile and toxic. So we admitted the child in ward, and the other system examination thing normally, except there's mild hepatomegaly, pump hepatomegaly. So initial investigation, the CRP was high, the counts were normal, platelets were normal, and RT-PCR for COVID was negative. So we started on empirically antibiotic considering it's an enteric infection and waiting for culture. Next slide, please. So on day 3, the culture report came as negative. The child had persistent fever. While examining, the child had neck stiffness and carrying sign. So we suspected bacterial meningitis. We did lumbar puncture and MRI for this baby, and the CSF findings was within normal limit. And the MRI again was classical of class, that is cytotoxicity in the corpus callosum. As I earlier discussed one case, you people may remember this earlier case, that baby was present with altered sensorium and COVID RT-PCR was positive, and the child also have the similar lesion like this cytotoxic lesion of the corpus callosum. But this child RT-PCR was negative, but this child also had cytotoxic lesion in the corpus callosum. Not only that, subcortical white matter also involved in this baby, sir. So we thought this baby initially 4 days fever, now 6th day fever with the meningeal sign. We initially thought of meningitis. So that we did MRI and LP. Then the MRI was suggestive of this clots. Then again we repeated our investigation like the inflammatory parameter. Next slide, please. Inflammatory parameter. The CRP is gone up to 141 to 331, and the D-value was high. There was a dropping platelets. We did the emergency functional echo in this baby. There was a pericardial effusion and mild LV dysfunction, and the IgG was positive. The antibody was positive. So this could be a very different case. We initially suspected meningitis, and this turned to be a COVID sequelae. This is a post-COVID sequelae, CNS involvement of the post-COVID sequelae. So again, this child fit in the category 3 MASC, as the child had a cardiac involvement and the rising inflammatory markers because of this CRP is rising. And myocardial dysfunction is there, so this child is put in the MASC category 3, and we started on IVIG and pulse meter prednisone. During the therapy, the child improved well, and the D-dimer and CRP is decreasing trend, and we did echo before this, it was normal. The child is doing well with the oral striation. So this is a different manifestation of CNS in post-COVID sequelae.
Post-COVID.
Yes.
So the IgG was
positive. RT-PCR was negative.
And the LP was normal. So roots out other bacterial infection. Okay.
And blood culture also negative.
Negative. And MRI showed evidence of COVID evidences. Clots. Is there any other type of manifestation that you have?
Yes. The another case I want to discuss is the 9-year-old male present with a fever of 3 days and abdominal pain and vomiting 2 days. On trial, the child was present with shock, peripheral pulses were not palpable and was in hypotension. Forward was distended, diffuse syndrome was plus, and we managed the child with IV fluids and other supportive measures. We did a functional echo for this patient. This LV function is normal, and there was a collapsed IVC, so there was a hypovolemic shock. So we managed child with the IV fluid correction, and the abdomen was distended, and there was a guarding rigidity was present. So we suspected acute abdomen. We proceeded with the next set of investigation to note the cause. The total count is high, the CRP is positive, and the serum amylase and serum lipase was highly elevated. It's suggestive of acute pancreatitis. In this COVID era, so the any patient present with shock or the multi-organ dysfunction, we should do COVID testing also. We did COVID RT-PCR for this child, it's come to be negative, and COVID-19 IgG was positive, and CT abdomen was suggested for acute necrotic. So this case again multi-system inflammatory disease of children category 3, because the child present with shock and there is evidence of multi-organ involvement. There is acute necrosis in pancreatitis there, and there is a significantly high inflammatory markers. The D-dimer has more than 10,000 and the CRP is 300. So again we manage the child is next slide please. Again, this child is IVIG and pulse methylprednisolone and IV fluids and antibiotics and other supportive measures. The child is improving now and oral steroids.
Yes, sir. Suresh, you want to say something?
Dr. Meghnad, I have a question. You manage this child as acute pancreatitis, but there are other causes for acute pancreatitis.
Yes, sir.
Did we rule out those cases?
Yeah, we did the child triglyceride level, serum calcium level, and parathormone level. All we did for this patient. All came to be negative, and the blood culture also turned to be no growth in the blood culture. So we ruled out the other condition. Only the explanation for this pancreatitis could be the COVID-19 associated. And there has been case reports has been reported that COVID-19 post COVID sequelae they presented with the pancreatitis features also.
So there is the evidence of COVID here. There is evidence of multi-system inflammatory markers, rise inflammatory markers, and pancreatic enzymes has been elevated, and you rule out certain other causes also. So it is COVID associated or COVID induced pancreatitis. That is what.
You had literature evidence.
Yes, literature also the case reports for this pancreatitis.
Is there any other case, any other experience that you have got? Like
these two cases are very interesting cases.
Yes,
sir. The next case I want to discuss this next is another interesting case, and there are so many confounding features in this side. This is the 14-year-old female present overset with vomiting, giddiness, and altered sensorium for 3 days. Referred as a case of suspected ITP with the platelet counts of 16,000. There was a history of gross hematuria. There is no history of fever at all. And receiving to trial, the child was human stable, confused, and talking irreverently. There was a petechial hemorrhage, petechial spots in the both upper limb and lower limb. Malar lash was positive, and acanthosin agonist was present. So this was a bit confusing to us whether it's ITP or it's SLE. So we again proceeded with the next set of investigation. Next step please. Next step please. So as the child present with confusion altered sensorium, the MRI was already taken. It was normal. So any low platelet and altered sensorium and confusion could be intracranial hemorrhage. So the MRI was normal, and again in our side we repeated the counts. It was again bicytopenia, the total count of 3,800 and the platelet of 11,000 only. The ESR and CRP was mildly elevated, the normal renal function, and the SGOT SGP was elevated. So in this conclusion, we thought it could be a bicytopenia is there, and malar rash is there, the altered sensorium is there. There was a hematuria also picture is there. Could be SLE. So we thought of SLE. We again further evaluate the baby for the next set of investigation while stabilizing the baby. Next slide please. And the ANA and ASGNA was unfortunately negative, and the C3 C4 also negative. And this COVID IgG was positive in this child, and serum fertility is very high. It's 14,000. So the LDH and D-dimer are also very high. We thought of this could be a COVID associated HLH. So we ruled out this SLE, and this could be a COVID associated HLS. There has been supporting evidence and supporting literature also. Therefore, there has been case reported as COVID-19 associated HLS. We managed this patient with methylprednisolone for 3 days. The child improved dramatically. Then the next day itself, child become conscious. Child talking very relevant and oriented, and the platelets were very improving trend, and the child was successful with normal platelet counts. This is very tricky case, sir. Actually, we thought initially some parameter there. Initially, ITP was in mind, and then altered sensorium. We thought it could be IC bleed, and the MRI is normal. and then the high 13 level, we got HLH and thought to be a COVID associated HLH.
Okay, SLB is just thought and they ruled out SLE also.
Yes, sir.
Okay, that's good. And you said steroid is started.
Yes.
Before going for other things, there are few questions. Just two or three questions. How long will you continue the oral steroids in follow-up of PMS, MAS?
Actually,
MAS.
it is the recommendation is 1 week of steroids to 2 weeks of steroids and taper over the next 2 weeks. So it's about 4 weeks of treatment.
And another question they asked how to categorize 1, 2, 3, and already
We
you
have
told
said that.
detail.
Category 1 is a mild illness. Category 2 will present more like Kawasaki with some cardiac involvement. Category 3 will be shock. Basically this, we can have some additions in it.
Okay, fine. And another one more question: how the children are differ from adult in the laboratory investigations, radiological interpretation? You use ivermectin in mild COVID patients.
I can explain, sir.
Yes.
We use so many patients. So usually the laboratory parameter wise, in acute phase, I have seen we have managed so many patients, around 100 patients we have managed. None of them have in the acute phase, none of them had elevated inflammatory markers as CRP, D-dimer, ferritin. None of them had elevated parameters. They had mild symptoms, are usually asymptomatic with that way. Apart from any other system involvement, like in the intercession case, also there is no much elevation in the inflammatory marker. And another case I discussed in the acute COVID infection, the cytotoxic reaction of the corpuscle. In that case also there is no increase in the CRP level. So usually adults will present with immediate that hyperinflammatory syndrome. They were present with pulmonary complications, like they had a high CRP and high D-dimer, and the CT score is very severe. But pediatric age group in acute phase, the inflammatory markers are not elevated, and the lung involvement is very minimal. We can tell nil in acute phase case.
I think out of more than 100 CT, only 2-3
Yes,
CT
sir.
showed
We have had statistics. So we have done more than 500 cases we have dealt. So 100 cases we have done positive cases. So in that only 2 CT positives are there we can be able to pick out. Sir.
CT finding in pediatrics.
In pediatrics, only in terms of
very less in our experience.
Yes.
That's good. Thank you, Meghalaya, for that lightning. And one more question to Dr. Sendil. Asymptomatic newborn, can it transmit COVID?
Yeah. This can be either way. Can come to the mother can to the baby and from baby can.
Baby also can transmit the baby.
Must take universal precautions whenever any of the combinations will be.
Don't take any risk. Even if it is baby, don't take any risk. That's fine. Okay, so far we've been seeing all complication, all severity. They say pancreatic, they say COX, they say HLH. All really ஒரு பயம்தான் வருது இதெல்லாம் பார்த்தாக்க. Vignesh, all of the cases you've been seeing that COVID or MAC is so sick, or are you seeing the mild cases also?
In past 20 minutes, me and Dr. Meghalaya, I think every audience we failed, I think. So we should not always think that all the MAC should not fall in category 3, sir. So we come across MAC category 1 also. So I want to share a few cases with you. This is a 3-year-old female presented with a day 5 fever with abdomen pain and swelling of face and legs with subconjunctival congestion for 1 day. Next slide. So child, when on age, child was little febrile and is hemodynamically stable status. Next slide. So in this COVID era, any child with febrile for more than 5 days with subconjunctival congestion, we will do a tier 1 investigations. So in this child is having a high inflammatory markers. So COVID IgG was turned to be positive in this child and elevated D-dimer and ferritin. So as any child will come with COVID IgG positive, we will do echo, bedside echo. Echo was normal. Next slide. So the point I want to stress is all the MAC patients are not fit into category 3. Some simple category 1 also will see. So we should not hurry to go to IVIG and meet with prednisolone. Unnecessary patient will be panicked. So this is a case of MAC category 1, multi-system inflammatory syndrome, the category 1. For this, we should only fluid management and proper supportive care as enough. Main treatment is low dose steroids. For this child, we are treated only with oral prednisolone of 2 mg per kg for 7 days, and we stop it and stop. all the parameters now. The child came to review, all the parameters are normal. Child was afebrile, child was happy.
Okay. Is there any other form like so? Categorization is very important here in the management. Suppose if it is you see a lot of mild category 1 also doesn't require any IVIG or
Yes,
complicated.
Yes, that's what's the
Just
main
simple
category.
steroids
Yes,
will
yes.
do. Is there any other form of simpler manipulation? Any other interesting experience that you have?
Yes, sir. Yes, sir. Next slide, please. So another case is a 1 year 6 month old male child presented with only fever day 6, no other specific complaints. On examination, child is alert, afebrile, hemodynamically stable. Next slide. So we done a lab investigation. So this COVID era, all child with febrile we should always think of COVID. So we should think in mind and we came with CRP was positive, CRP was highly elevated, more than 50. I think this child was 65 and elevated ESR. At D-time was came to more than 1000. So COVID IG was turned to be positive, sir. So we are not hurry and started CS. Only child is having only fever, no other subconjugal congestion, no other rashes, no other symptoms, only fever. We didn't start steroids at this point. So on child has had fever at day 2, day 3, sir. So we didn't start antibiotic, we didn't start steroid also at this point. So on, so we look for other causes, we look for other focus also. We done a chest X-ray and ultrasound. In this point, ultrasound we have a look for evidence hypoechoic lesion in the right kidney. So the child is having evolving renal abscess. So next slide. So this is a case of COVID IgG positive, but this is not considered as a MAC. So the cause for the COVID IgG in this case, COVID IgG was positive. The cause for fever in this child is evolving renal abscess. This child is treated with appropriate antibiotics. So child was completely afebrile without the steroid, without unnecessarily get started a steroid. As Suresh earlier said, if there is evidence of local infection, any sepsis, MAC is not coming, so not coming with diagnosis.
That's great. So in this case, there is an evidence of focus of infection in kidney. So MIS is not considered. It is only treated as an renal abscess. And COVID IgG positive is merely an association.
Yes, yes.
It is not an MIS.
Yes.
Wonderful. So great experiences from all of you. I think we have talked all about all the systems: CNS, renal, cardiac, gastrointestinal, SLH, newborn, everything, no? So, Suresh, ரொம்ப நேரம் நிறைய பேசி கொஞ்சம் இதான மாதிரி இருக்கு. So I just wanted to summarize when I go out of here, what I should take.
I don't know what you are going to take, but I'm hoping you will take us for dinner.
So, serious matters. The take-home message in this would be suspect MISC, multisystem inflammatory syndrome in children, in a child with acute febrile illness for more than 3 days, and if they have raised inflammatory markers. This is the first take-home message. So we should think of MISC. It is not always MISC, but we should have this in the back of our mind. That earlier we were saying, if you have a CRP positive, ESR is high, you think of a bacterial infection, we will do a urine and blood culture, start antibiotics. Also have MISC in the back of your mind as a diagnostic possibility. This is the first take-home message. Second is, if there is a chance, if the COVID IgG is positive, there are 4 categories. One is there is no MISC, like the child with the renal abscess. There is a category 1, which is the mild inflammatory changes that we found in one of the children. Category 2 and category 3, let us categorize rigidly according to what the guidelines say. Unless we do this rigidly, we will either undertreat or overtreat cases of MISC. Because treatment with IVIG is expensive. Methylprednisolone is also an expensive drug. We should not use it unless we are definitely categorically made a diagnosis of MISC. Category 2, category 3. Category 1, oral steroid will do. Category 2 and 3 need care in an ICU with round the clock intensive monitoring. Next slide, please. The take-home message again, the third take-home message is, as far as MISC is concerned, 20% is diagnosis, 20% is treatment, drugs. 60% is supportive care, which is what all these children receive to get a good response. Supportive care in the form of daily echoes, IV care, outputs, input from other consultants, cardiologists, nephrologists, neurologists at times, a radiographic department that can give us very good reports. All these supports are necessary to manage MIS.
Sunil, is there any point from you regarding the newborn take-home messages?
In this COVID time, don't be aware that don't hesitate to take the baby for the industry whenever they have a fever. So fever is a deadliest symptoms. Be very aware that must be very aware that be in cause for an COVID. So when the fever is not subsided, for not 2 days, the as a already fever will be treated in an only in an. So when the fever is not subsided, so as a treating doctor, don't forget to look for an inflammatory marker. If inflammatory markers are raised, don't hesitate to start a steroid, earliest steroid. So that's the one thing I want to convey is fever on third day, if you are not getting saturated with normal antibiotic, look for an inflammatory markers as well as take a swab on day 2 itself. Whenever there are any baby with fever, because not only as babies coming with an respiratory distress, COVID babies, can also having an with seizures or GI symptoms. So first awareness is important, and the sign known as Professor Suresh rightly said, supporting care is very important. So awareness towards and diagnosis of COVID first, and supportive care is second, and third one is comes on early initiation of treatment, especially steroids. That's all.
Good, thank you.
And don't ever stop on breastfeeding. Whatever may be the thing, continue breastfeeding.
So if you don't say that, then neurologist cannot be like. There are certain few questions. I think just another 2-3 minutes we'll just wind up the session. There are few questions to be answered. One says, Dr. Rajendra, I think, I did not get any book about MISC in children. Is there anything literature? Is there any that you can suggest to the doctor?
There are no books. The illness itself.
Their disease is only a year old, and MISC is a few months old. But we can send journals and links to the phone number that we can pick up from your question, and definitely we'll send you a link. It is available in the net, sir. The studies on MISC is available in the net.
Recent updates.
Recent updates. All after May, June.
Then another question, what is your experience about remdesivir and other drugs that adult?
No, we have very little experience with those drugs. None of our acute cases we have had to use.
In our experience,
None of the child needed, sir. Actually,
Needed.
None of the studies needed.
actually this drug
None of the till we have seen so far 100 cases and we are seeing almost 6 cases, 30 cases. None of the patient need of remdesivir. So still the proper care and the proper bedside echo and proper monitoring. So we didn't go for remdesivir also till this point.
I think I strongly feel these are drugs, it's an antiviral drugs. Indicated more in acute cases, not in MASC. Because MASC, it's an inflammatory disease, there is no active illness here, it's only inflammation going on. I think there is no role for remdesivir or
in MASC.
But in acute infection, the baby is not manifesting in the very severe form to use what our experience. And what is your experience with the CT angiogram for seeing coronary aneurysms, coronary anatomy?
Yes, sir. I can. We can explain. Actually, basically, to getting the CT angiogram is tougher in children. But CT angiograms coronary is the heart rate should be at least minimal, at least 60 or 70 or 80. Usually, our children is very difficult to set it as a CT itself. So very tough. So echo is very better modality. You can very well appreciate that CT coronaries in the echo. If you high resolution in the echo, it's an experienced cardiologist, you can very well pick up. Nowadays, we pediatrician also trying to pick up the coronary aneurysm in earlier stages. So, exposing the radiation for the CT angiogram, it's better. Echo is a better modality to for the
So
current
echo itself is will do and
Yes, we can
probably you should be trained
Trained
for
for-
seeing
yes,
uncoordinates.
sir, yes, sir.
If you are trained echo itself, we can easily identify
Even
the
the
echo performance. And another question they have asked. They answered all the topic. First one, father was positive. That patient got affected after that. Is that once again easy risk of from the kid? But I am not able to understand this.
Is the
Probably-
father at risk from the child?
Father,
the
yeah,
father
I'm
is-
not able to clearly understand what they are what they are trying to ask. Probably there are two questions. One, they said 1 month back the father had, then how the child is been affected, MASC. That may be the communication. The another thing is the father once again is at risk for this. These are the two possibilities.
Father would have had an infection. Probably the child would have picked it up from him and been asymptomatic during that period and developed antibodies which is causing the disease. That is one explanation. Because the time frame also fits in. The father had 10 days later, the child has, then 14 days later he develops antibodies. That's about 25 days and this illness starts. So that is the time frame. It is unlikely that the father will pick it up back from the baby child because now the child already has antibodies. But reinfections have been reported off and on in some places, and more studies are awaited about it.
Thank you. Probably that explains that way. There are another. Any child with the MIC category 1 worsened to the category 3. If yes, what was the duration?
Yeah, you want to answer the question?
So far, me and Dr. Meghana and Dr. Suresh have seen so many cases. From till now onwards, any child we didn't see from category 1 to jump to category 3. So any child coming with cardiac came with LV dysfunction with cardiac hypotensive shock. So that itself came with category 3. So I want to pinpoint no child from in our unit from category 1 to jump to category 2 or category 3. So either they come with category 1, they smoothly treated, they are discharging. They came with category 3 itself, we treated as per protocol, child was discharged appropriately.
So probably your high index of suspicion and
Yes.
experiences that you are able to pick it up in whatever they come.
Yes.
You are not allowed them to change over from one to the other. There is another interesting question from us. Since the window to shock from start of MASC is narrow, is there a way to pick up patient who will deteriorate from OP patient for a referral?
Question. So,
It is difficult to answer. Any question that comes with an answer saying it's a good question always comes with a bad answer. We really do not know what are the markers that will say that this child will slip into shock or will not slip into shock. But as always, shock does not happen suddenly, it is discovered suddenly. There may be some mild markers. I would go with altered sensorium, the usual first line, rapid respiration, altered sensorium, and some alteration in our blood pressure monitoring, blood pressure. If there is some drop, and if there is a rising trend in the CRP, then I would suspect that that child may go into shock and has to be monitored more carefully. One of our problems is that we don't check BP regularly for all our outpatients. So we do not know when a child walks into our IP what the BP was earlier. So monitoring BP regularly in our outpatient, we'll have to start at that point, and then some change in the BP, some change in the heart rate, and a high index of suspicion. I think we can prevent child from.
Yes, no, I don't find. Usually we used to see dengue-like patients. The pulses are tricky side in this. By whatever our experience, the pulses are very tricky. In dengue-like illness, we used to do palpate the peripheral pulses. Usually feeble or weaker options. In this case, especially when the cardiac environment is that the pulses are bounding. Sometimes you may miss the patient, the pulses are bounding, the pulses are powerful, very good. We should take the BP, sir. If we check for the BP, the baby was in hypotension, the pulses are bounding. Sometimes we may miss the
Giving a
patient.
septic shock.
Septic shock. So it's multi-inflammatory syndrome, it's a bounding pulsar. So sometimes we may partially miscarry because the pulses are very good. While doing the rounds, the pulses are very good, so child is stable. We should not miscarry, sir. We should take the BP also, sir.
Okay, probably the simple BP monitoring will help this,
Yes, I think
help
so.
them to control. Yeah, thank you, Dr. Suresh, Dr. Sendil, Dr. Meghanathan, and Vignesh. One last thing, that when you have a discussion with all these things, I remember called Dasavadara. That is what strikes me. So COVID behaves like it varies from various, it manifests in various forms. Um, it starts with interception, it's a cardiac manifestation, nephritis, HLH, ENS, and simple asymptomatic Indian newborn, simple association. So various manifestations it makes. It's the corona remembers me about the Dasavadaram. Probably at present it's Dasavadaram. After some time we don't know how it will turn out. But somehow definitely it's good talking to you, and it's a wonderful experience that we shared, and hopefully it will benefit some of the doctors who are listening to this. Thank you all once again for this wonderful sharing the wonderful experience.
Thank you,
Thank you,
thank you,
sir.
thank you, thank you.